Friends, today is the second lecture in the series of fetal echocardiography. In the first lecture, we had seen the indications of fetal echo, when to do, how many times to do, and in which situation to do. And also one most important fact which we understood in the last session was that we have three types of scans available. The basic scan, which includes only a four-chambered heart, an extended basic scan, which includes the outflow tracts, and the fetal echo. These are the three steps where you could see the heart. However, the basic scan is known to pick up only up to 50% of the heart diseases, in contrast to the extended basic scan, where 80% of the heart diseases can be picked up. Fetal echo is usually indicated in high-risk mothers, and all the indications we went through last month. So amongst the basic and the extended basic scan, which could be a part of the anomaly scan, the extended basic scan is the one which is recommended now to pick up maximum number of heart diseases, or at least suspect, so that they are sent for a fetal echo. Remember that an abnormal suspicious cardiac four-chamber or an outflow tract is the most commonest indication which has the maximum yield to pick up a congenital heart disease. Now, an extended basic scan and a fetal echo, they're almost similar, and today we will learn how to do that stepwise. So today what we will do is, we are going to have the talk into three parts. The first is the basic considerations. Second is the anatomic survey, and third is the functional assessment. The anatomic survey is the one which is going to be a part of the extended basic scan or a fetal echo, because fetal echo additionally will also include the SVC IVC view, the arches, and also the three vessel view. So now let's see, before we start our initial basic understanding, let's see what things we can manipulate on the machine. So we usually use the curvilinear probes, and the curvilinear probes have different depths. So the principle remains the same. Higher the wavelength, lesser the penetration, better the resolution. So the same principle which we use in pediatrics holds true for fetal also. Curvilinear probes are preferred over cardiac probes because the amount of coverage and the scan plane is much bigger compared to a cardiac probe. However, we come down to the cardiac probe in situations where we need a Doppler gradient which is more than, for example, 20 meters per second. This is only because when we are in a fetal echo preset, only PW, the pulse wave Doppler, will work. The continuous wave Doppler will not work. Second is, sometimes the machine is calibrated for calculation of the heartbeats in a different way. For example, 2 cardiac cycles is considered to be equal to 1 in fetal preset. So this is something which is very important. And if your machine is calculating like that, then you go back to the cardiac preset and use CW for calculation of maximum velocities, and also for calculations sometimes for heart rates, etc. The second thing is, you do need higher frame rates, and higher frame rates is going to give us better quality of image. How do I get that? You adjust your depth properly. Depth is something which is worked in the same way. You need to have the picture which occupies 2/3 of the screen, and to magnify, you can use things like width. So you adjust the width to narrow down your sector, and also use the zoom button. Now in the zoom button, the same principle. If it's a pre-processing zoom, it works much better, and the magnification will not deteriorate the quality of image. The focal zones, all of you know that some machines will have one focus, some will have two, and this focal zone also helps in improving the quality in that area. And then the cinelope, which is most important, because so many times you would want to go back to that clip and review your understanding. So make sure that your arrangement on the machine is done ideally before you start. Remember, for fetal echo, we do not need any extra precautions to be taken or preparations from the mother's side. It's important for the mother to come after having her breakfast or food, and not to come on empty stomach. Specifically need to inform the mother that full bladder is not necessary. It's important to counsel the mother. It's important to counsel the mother that, this test is a little long-lasting test. and not to be apprehensive during the study. The starting, we are going to see just a gross idea of how the imaging is done in fetal echo. So this slide is important. Now, remember that most of the cuts in fetal echo are axial. Axial means what? In this picture, if I see, axial is this way. For example, this is axial. So the first most important viewing we will start is with the situs. Situs is where you have an axial cut which cuts the aorta and the IVC this way. This is very similar to our subcostal view where we start at the level of the diaphragms. The next axial cut is going to be a 4-chamber view. So a little manipulation from the situs, we will cut the heart in an axial section giving a 4-chamber view. The 3-vessel view, you can see here the SVC, the aorta and the PA. All in one cut, we get it in a 3-vessel view. A little modification from the 4-chamber view, we get the outflow tracts, which would include the left and the right. And then we have the bicable view, which is completely in a different plane. However, a little modification from the bicable, we will get the arches, which would include the aortic arch and the ductal arch. So the aortic arch, ductal arch, and the SVC, they will all be in the same plane. So to start with, usually we start with situs, go to the 4th chamber, a little modification from the 4th chamber, we get the left and the right ventricular outflow tracts. From the 4th chamber, we get the 3-vessel, and then in a different plane, which is the sagittal cut of the fetus, we get the bicable, the aortic arch, and the ductal arch. Now, this is just a summary of what we are going to see in the coming slides. So, as you can see, you start with the situs. So, as we start, you can see here that this is the stomach bubble. How do you determine left and right? We will see in the subsequent slides. But for this particular baby, this is left and this is right. So now let's start understanding. This is the stomach bubble. This is the aorta and that's the IVC. You open up the heart. That's the 4th chamber. And this was the 3-vessel view. So in this particular sequence, we are seeing the situs, the 4th chamber, the outflows, and the 3-vessel view. So this is the 3-vessel view. The same thing in color, we start stomach bubble, situs, 4th chamber, LVOT, the red one, the blue one RVOT, and then the 3-vessel view. So these 4 things, they actually come in the same sweep. Sometimes the outflow tract will need a little modification, and then you'll have to completely change the plane of imaging to sagittal cut to get the bicable and the arch views. So now with this basic understanding, we will go to the first and the most important view, which is the 4-chamber view. This is something where you need to start and lots of important messages you will get in this view, which would include the laterality. Laterality means which one is right and which one is left for the baby, so that you are sure that your right atrium is on the right side, your right ventricle is on the right side, your great arterial relationship is normal, etc. You would also see the heart size, cardiac axis, and the position of the heart. And then you will see the individual components in the 4-chamber. 4-chamber view is not a complete understanding on its own. However, to start with, it gives a lot of basic clarity on important things related to the heart. We will also see what all we can see in a 4-chamber view and what all we cannot see. Now, this is an important understanding where we will try to figure out which is right and which is left for the baby. There are 3 methods which are used, and different methods, different people are comfortable with different methods. One of which is we find the fetal spine in relation to maternal spine and then figure out in relation to the mother's right and left. The second method is the right thumb rule, and the third method is the Cody's method. I find the Cody's method much more easily understandable. So this is what we are now seeing. where first of all we need to decide the lie of the baby. The lie of the baby could be in different possibilities. You can have the head on this side, you can have the head on this side. But remember, the head needs to be coming on the left side of the screen. So once the left side of the screen has the head, so you can see this is the head. If it is on the right, you can use your left-right button inward to bring the head here. Remember, never ever to use the UD button. You can't make the fetus upside down, otherwise your understanding of right and left will get distorted. But you can use your left-right button inward to bring the head on this side of the screen. Once the head is on this side of the screen and the baby is lying like this, you need to rotate your transducer clockwise 90 degrees. So you rotate your transducer clockwise 90 degrees. From a sagittal cut, you will get, from an axial cut, you will get from the sagittal cut, you will get the axial cut. So this is how you will cut the thorax. Once you cut the thorax, you will get, this is the spine and this is the sternum. This is the sternum and this is the spine. The heart is here. You need to use this figure to decide which is left and which is right. For example, this is the spine and this is the sternum. So it fits into this figure, spine and sternum. Then this is left and this is right. So for beginning, you could keep this as sort of a print in front of your echo machine so that you can compare all four possibilities, baby lying based on the sternum and the spine. You could decide which is left, which is right. What I practically follow is that I stand in the position of the heart facing the spine. So if I'm standing here facing the spine, my left is baby's left. So in this, I have the heart here. I am looking at the spine. This is left and this is right. This is posterior. This is anterior. So whichever way the baby is lying, bring the baby in a sagittal cut, head towards the left side of the screen, rotate the transducer 90 degrees clockwise, and then you stand in the position of the heart. My left is baby's left. So now once I understand which is left and which is right, then I run through the sequence of events about the visceral situs, atrial situs, etc. So after this understanding, we will go to how to understand the visceral situs. Now, if this is the axial section and we understand that this is posterior, this is anterior, this is left, and this is right. I need the aorta to the left and IVCs to the right of the vertebral column, the stomach bubble to the left. This is what is going to decide my visceral situs soleus. So this is left, this is right. I make sure that my aorta and the stomach bubble are on the left side and IVC is on the right. After I have done this, I will go to the four-chamber view. So when I have the four-chamber view, I can double check my cardiac axis, size and position. Now, how do I decide my cardiac axis? So this is spine and this is sternum. There are two lines imaginary which we need to draw. One is connecting the spine to the sternum and second is passing through the interatrial septum and interventricular septum. In fetal life, you can actually connect the IAS and IVS in a straight line. This is what is going to give me an angle, and normally it is around 45 degrees plus or minus 20 degrees. So if it is more a leftward axis, this is going to come here. That means my axis is going to be more leftward, which could indicate a possibility of outflow tract abnormality. Normally up to 65 degrees is acceptable. So this is basically the cardiac axis. If this comes to lie here, that means the heart is a little bit more apex oriented towards the left. It's more leftward axis, which correlates with outflow tract abnormalities. The cardiac size, you could compare it with the circumference comparison with the chest, or also the ratio with the chest, and normally it should not exceed more than 45%. The position of the heart in the chest is important, that the whole mass should be lying on the left side of the chest with the apex base relationship towards the left. That means it should be levo position with levo cardia. So these three things can be picked up in the four-chamber view. The cardiac size being normal, the position being normal, and axis being normal, you move on to the four-chamber view. So here, this is a similar repetition. This is an axial section which is taken at the closer to the apex of the heart, which is going to give me a four-chambered view. Now, so let us see this. You start with your four-chamber view where you have the stomach bubble, aorta, and IVC. So this is what is the visceral situs, and then you start moving the probe a little bit. As you know that this is a little lower part, and then when you move a little up from the visceral situs view, you will come to the four-chamber view. And then the four-chamber view, once you enter, you will realize that the left side and the right side. So you open at the two atria and the two ventricles and the two AV valves. So it's just a little sweep from the visceral situs and make sure the IVC enters the right-sided atrium. And then you see the flap of foramen oval, the AV valves, the ventricles, the interventricular septum, the interatrial septum, and the pulmonary veins onto the entering the left-sided atrium. Basically, this is a cut which is axial just above the diaphragm, just above the situs levels. You will have terminologies being used like apical, basal, and axial. This is where the apex is down, up, or horizontal, and these views are important. Even in a four-chamber view, there is some sort of a difference. We will see in the subsequent slides what difference and which view is better. So the most important thing is that correct technique, you need to have only a single rib which is encircling in a four-chamber view. One full rib. If you have more than one ribs, that means your cut is a little slanted. It is not exactly 90 degrees in an axial plane. Also, that the crux of the heart has to be visualized. As you see here, the crux of the heart seen is a correct four-chamber. You need to see the crux of the heart, the junction where the interatrial septum, interventricular septum, and the AV valves are seen. So this is what indicates that it's the correct four-chamber view. Now, what are the components we see in a four-chamber view? As we understood, we get a lot of information, but it's not complete. So you can see here, you see the morphological right and left. How do we decide? We decide based on the same principles of a trabeculated right ventricle, a slipper-shaped, smooth left ventricle, and the AV valves which go with the ventricles. The second most important understanding is the proportion of the right is to left. Proportion means in the earlier part of gestation, the cardiac chambers are usually proportionate, but as pregnancy advances, the right ventricle usually becomes the dominant ventricle. So in general, we need to understand that in fetal life, the right ventricle should be equal to or slightly dominant than the left. There is a ratio which is acceptable, which ranges from 0.9 to 1.1 is to 1. 0.9 to 1.1 is the right ventricle, left is 1. That means maximum is 1.19 right ventricle is to left ventricle, a little more dominant right ventricle. We don't want the right ventricle more than 1.2 is to 1 compared to the left ventricle. The second most important thing which you will see is the flap of foramen oval, which is seen towards the left atrium. So if you see a flap towards the atria, that atrium is the left atrium. The size of foramen oval is important. There is something which is called premature foramen oval closure, especially in the third trimester. And in that situation, it's important that you compare it with the aortic diameter. However, there are other ways to decide. So in general, If it is freely opening with no turbulence and the size looks adequate and the flap is into the left atrium. This is the interatrial septum. You can also see the primer segment. The two AV valves and the offset, which is very important. So this is the tricuspid valve. Sorry, this is the tricuspid valve and this is the mitral valve. So the difference in the insertion is very, very important. Remember that the difference is just going to be 8 millimeter per meter square. The baby is 200 grams, 300 grams. So that difference comes to 1 or 2 millimeters. So it's very, very important to try to make sure that you have differentiated the insertions and it's not in the same plane. As to pick up small primum ASDs and small inlet VSDs may not be possible in fetal life. You will also see the descending aorta behind the left atrium. So it's very important that the gap between the left atrium and the descending aorta is not much. The next thing is the pulmonary veins. We need to make sure that this left atrium, the shape of the left atrium looks like pulled ears. It's typically understood as pulled ears as if there's something which is pulling the ears. This appreciation is important. If the left atrium looks bald and there is a gap sort of a chamber between the left atrium and descending aorta, all of you know what to suspect. It could be a total anomalous pulmonary venous connection, TAPVC, which is otherwise difficult to pick up because of reduced pulmonary venous rhythm. Remember, in fetal life, there's only 10% of the cardiac output into the pulmonary veins, so flow may not be very well appreciated in a TAPVC. On color Doppler in a normal heart, you need to at least see 2 or 3 pulmonary veins into the left atrium. Partial anomalous pulmonary venous connection cannot be ruled out in fetal life. So I think these are the main components to be paid attention to. And on color Doppler, you will double check everything, including AV valve regurgitation, any presence of VSD, etc. Don't forget the pericardium and don't forget the contractility, a gross understanding about the heart rate. So you have a checklist. Now, after every single view, you will have a checklist to make sure that you have gone through everything. So in a 4-chamber view, you need to make sure that your stomach, descending aorta, the heart and the apex of the heart are to the left. The right atrium is to the right of left atrium and the right ventricle is to the right of left ventricle. Make sure that the AV valves have an offset. Both the ventricles should be reaching the apex. Both the ventricles appear similar, or are we a little dominant in size? The PFO size should be almost equal to the aorta, and the left atrium should not appear bald. It should be like pulled ears. So these are the things which you need to go through before coming out of the 4-chamber. There is a very important pitfall in a 4-chamber view, which is having a false dropout in the interventricular septum. VSD is one entity which I feel is still difficult to be sure of, especially if it is small or moderate, in terms of missing it also, and in terms of having a false positive defect. And as all of you know, this is because of our ultrasound principle, where if the sound waves are falling exactly parallel to the septate, interatrial or interventricular, you could see multiple artifacts which are actually not really there in terms of a defect. And so here you can see on 2D also, you can pick up multiple defects in the interventricular septum with some amount of bleed which happens also. These are called bleeding artifacts in fetal echo. This is how they will look. However, in that situation, you need to go into the axial section where your apex comes to lie on the right or the left side, and make sure that you do not have a VSD. So always remember, if you see a defect in the apical or basal plane, bring the heart in a horizontal way in an axial cut and make sure that you rule out a VSD. I still personally feel ventricular septal defects sometimes are a little difficult to pick up if they are small, as all of you know that the pressures in both the ventricles are same. So missing a small defect and also seeing a defect which is not there, both of which are there. However, at the end of it, it does not make a difference for us. In terms of management, counseling becomes very important in that situation. We are not going to go into the abnormalities today because our today's talk is only normal views, anatomical and functional survey. However, in a 4-chamber view, we will understand what all can be abnormal. So you start with the atrioventricular valves where you can pick up a atrioventricular septal defect, or if there is mitral or tricuspid atresia. Also the relationship between the atria and the ventricles. If I have the atrial situs solitus or inversus, and I have atrioventricular concordance or discordance. If I have a double inlet left ventricle, I can pick it up in this view. Ventricles, if I have a hypoplastic right or a left ventricle, I can again pick up in this view. I have an Epstein's anomaly of the tricuspid valve, I can pick up in a 4-chamber view. Hypoplastic left heart, yes. Sometimes indirect concerns like a left ventricular hypertrophy or dysfunction, which could be related to aortic stenosis. So I may not come to the diagnosis, but I will know that there is something which is wrong in a 4-chamber view. If I see an area behind the heart, extra between the descending aorta and the left atrium, I would suspect a TAPVC. I can see sizable VSDs which are in the inlet area and the muscular septum. Also remember that in a 4-chamber view, you have an overall understanding of the function, rhythm. Any rare things like tumors and aneurysms also can be picked up in a 4-chamber view. You will realize there are lots of things which we can still not see in a 4-chamber view. And as we know, this is going to give us an information of 50% of heart diseases in terms of percentage. Now we come down to the next important view, which is the outflow tract view. So as you saw here, our previous cut was in an axial section just above the diaphragm. And now from here, there are 2 ways where we can get the outflow tract. One is with sweeping. So as you can see here, you just need to sweep from axial section and bring that cut still axial but closer to the outflow tract. So you just need to sweep anteriorly, or sometimes you might have to rotate the probe. Rotation is in terms of clockwise or anti-clockwise. Sweeping is in terms of tail down or anterior sweep. And this is how from a 4-chamber view you will land up into the left ventricular outflow tract and a right ventricular outflow tract. In a very simple way, this is very similar to our apical or subcostal 4-chamber view. So this is what we start with. So we have a 4-chamber view, and from this 4-chamber view, we are sweeping. This is the slipper-shaped left ventricle. This is the trabeculated right ventricle. And then you can see the outflow tract coming from the left, and further you can see the outflow tract coming from the right. So you would go through it again. It is not difficult. The outflow tracts are not at all difficult. You will see the 4-chamber view where you will see the mitral valve, aorta, and then you sweep further and you see the RV outflow tract. By the time you are reaching here, you will see that this is RV outflow tract. This is the further continuation of aorta, and this is the SVC. So how from an outflow tract you will end up reaching a 3-vessel view. So the outflow tract is not that difficult once you get the 4-chamber view. And what all are the components we look for? So this is the LV outflow tract. You will see a continuation between the mitral valve and the aortic valve. This is the continuation between the interventricular septum and the anterior wall of the aorta. You will also see the right ventricular outflow tract, which is crossing the left. So you know the the great arteries are crossing each other, which tells me that they are normal. Then I land up with the 3-vessel view finally at the end of it. And I also can modify my outflow tract when I reach here to 90-degree rotation, and I can get the short axis from this view. This is very similar to what we get it in parasternal long to short axis, where I can see the branch pulmonary arteries. Sometimes I can see even in this view. However, here you can see the right pulmonary artery very clearly. The left pulmonary artery and the ductal arch will be overlapping. I can see the pulmonary artery and aorta ratio here in the outflow tract. And I know that my pulmonary artery should be a shade bigger than aorta, and aorta is going to be a shade bigger than SVC. This understanding we will see in the three vessel view. Color Doppler, you would come to confirm everything, the LV outflow, the RV outflow, any turbulence, any regurgitation, and the interventricular septum in the anterior aspect. So this is going to be the outlet area and the anterior muscular septum. So after going through this, I have a checklist again. So what all did I confirm? I confirmed that there is an aortoseptal continuity. When I use the word aortoseptal, I mean that the anterior wall of the aorta and the interventricular septum are continuous, and I have aortomitral continuity. My aorta and PA are perpendicular to each other. That means they are crossing each other. I have ventriculo-arterial concordance. In the four-chamber view, I saw atrioventricular concordance. And here I'm confirming there is ventriculo-arterial concordance. The PA and aorta size comparison I can check. There is no aortic and pulmonary stenosis or regurgitation. And a normal aortic arch. I will come back to that. How do I know that the aortic arch is normal? This is the checklist. So what are the lesions which I can pick up in a outflow tract? I can pick up outlet VSDs and anterior muscular VSDs. I can pick up a tetralogy because my aorta is going to be overriding. I'm going to have a defect below the aortic valve. I am not going to have a continuity between the interventricular septum and the anterior wall of the aorta. My great arteries are not crossing each other. I would know that this is transposition. I have an aortomitral discontinuity. I know I have a DORV. I don't have two great vessels opening. I know I have a truncus. I have aortic stenosis, pulmonary stenosis, and certain arch abnormalities. Like I have a right arch I can pick up. We will see how to decide whether it's a right or a left arch in the three-vessel tracheal view. So now with this, I have an understanding of left and right ventricular outflow tract. From here, I will move on to the three-vessel view and the three-vessel tracheal view. This is again a continuation from the RV outflow tract. I have the RV outflow, LV and RV. And then I can see here, this is my left and right. And where do I end is a three-vessel view. So here you can see even in the RV outflow, I have opened up the branch pulmonary arteries. So sometimes you can open a branch PS here, then you may not need a parasternal short axis type of a view. So this is the pulmonary valve, this is the aortic valve. And it still goes further, I can see the SVC here. So you can see the SVC, aorta and the pulmonary artery. SVC, aorta and pulmonary artery. So from here, in this view, you can see this is LV, this is the left, and this is the right. So what I have is SVC, aorta, and pulmonary artery. And remember that this correct sequence is very important, size is very important, and the flow is important. Sequence means what? My pulmonary artery is anterior leftward, SVC is posterior rightward. So this is the relationship. Here, you can see SVC, aorta, and PA. They have to be from left to right. PA is left, SVC is right. PA is anterior, SVC is posterior. In terms of size, I have the PA the most bigger, SVC the most smallest. And if I put a color Doppler, my flow in these two vessels is going to be in the same direction normally. This is a very important. Three things in three vessel view: the relationship of great vessels, the size, and the flow. The next important thing is the arches. Now, I will go back to this view for you to understand. The arch is usually done in relationship with the trachea. So, if this is the pulmonary artery, this is the ductal arch, this is the aortic arch, and this is the trachea. So the aortic arch runs to the left of trachea, forming a V here. This is the V, and normally a left aortic arch will form a V. This is the trachea. If my arch is right, the arch will go like this, where it's going to form a U with the ductal arch. So if I have the arches which form a V, then it is a left aortic arch. The color flow Doppler has to be in the same direction for the aorta and the pulmonary artery. So this is important. If it is not in the same direction, I have to worry about the semilunar valves, go back to the outflow tracts. Okay, so the checklist in the three vessel view, I see all the three vessels, SVC, aorta, and the PA, the isthmus and the duct. So when I open up the aortic arch and the ductal arch, the ratio should be more than 0.7. The aortic arch sidedness related to the trachea, make sure that it's a left aortic arch. The flow in the arches should be in the same direction, and the size, number, and position of the three vessels should be as we went through. So the end of three vessel and three vessel tracheal view, this is the information I will get. What abnormalities can I pick up? Remember that in transposition, I will not have the three vessels in one row. This is because my relationship of great vessel is not normal. Usually my aorta is anterior, PA is posterior. I end up seeing two vessels in the normal position. If it's a tetralogy of Fellow, my pulmonary artery is going to be smaller than aorta. Remember that the pulmonary flow is going to be very little in pregnancy. Your pulmonary stenosis is usually underestimated. So to pick up whether I have a PS physiology or a PAH physiology, I will pay a lot of attention to the size comparison of the pulmonary artery to the aorta. If my pulmonary artery is smaller than aorta, I would consider it as a PS physiology. Otherwise, it's just a large perimembranous malaligned VSD. Pulmonary atresia, aortic atresia, aortic arch abnormalities, and coarctation. So these are the things. Three vessel tracheal view and three vessel view are very important. So commonly, because the obstetricians and the radiologists are very comfortable with this view, they are the ones usually who pick up abnormalities based on this view rather than the outflow tracts. And they are actually very good in picking up aortic arch abnormalities like left arch with aberrant right subclavian, right arch, or even a double arch. The additional views are two. We understood that. From that, we need to now change the probe position and go to the sagittal cut of the fetus. When I come to the sagittal cut, I will have multiple things together, and I need to, you could start with the arches, you could start with the cable view. So this is a bicable view. Remember, this is very similar to the subcostal bicable view. And when I start, I see this. This is the head. This is the abdomen. And I can see this is the IVC, hepatic veins, and SVC. So the SVC is here next to the aorta. The SVC and the IVC. Remember, SVC IVC view is very important for few things: to demonstrate a normal venous drainage, and IVC which is not interrupted. In this view, you can see that this is the flap of foramen oval, which is towards the left atrium. The right ventricle is anterior, left ventricle is posterior. So this is the bicable view. I can demonstrate my IVC, hepatic veins, and the flow across the foramen oval is much better understood in this view. The SVC flow, and this view is also going to allow me to trace the ductus venosus. This is the ductus venosus. What is ductus venosus? You can see here the continuous flow which is seen below the diaphragm, and it will be seen somewhere closer to the IVC and umbilical artery. Remember that this is the only Doppler which will have a flow which is so peculiar happening in systole and diastole both. I practically feel that number of times when you open up the aortic arch, you see the ductus venosus very easily. However, from the IVC view also you can try tracing. So in this view, From the SVC IVC view, you have to do a little amount of movement to open up the arches. Now, you can see here that I have the SVC IVC view and I just sweep a little. I will open up the aortic and the pulmonary arches. To open up the ductal arch, I open up the pulmonary artery, and to open up the aortic arch, I will move closer to the aortic valve. Sometimes the lie of the baby could be a little curled up where it gets difficult. So commonly, if from one side of the baby you may not be able to see the arches, you completely go to the other side of the baby, and that could show you the arch much better. Most of the times, the ductal arch is easier to open up. Now, in this view, you can keep seeing it. Initially, when we are starting, we are seeing the ductal arch. How do I know that it's a ductal arch? Ductal arch is more stouter. You can see it comes anteriorly from the PA and it takes a turn and goes posteriorly. It is much bigger, stouter, and less curved compared to the aortic arch, which takes a beautiful turn and gives rise to the arch vessels, and it's a little smaller than the ductal arch. So this is how you will make sure the flow in the ductal arch and the aortic arches should be in the same direction. Now, if I cannot find the arches in this view, I can go back to the 3-vessel view and rotate 90 degrees, where I could also pick up the aortic and the ductal arch. So what are the components which I saw in the sagittal plane? I saw the SVC, I saw the IVC, I saw the ductal arch, and I saw the aortic arch. You can see here the ductal arch is much more stouter. Normally they compare the ductal arch with a hockey stick and an aortic arch with a candy stick. This is a little more thinner, little more curved, and gives rise to arch vessels. So these are the things which I see in the sagittal cut. Abnormalities, we went through it, that I can pick up IVC interruption. I can pick up the flow abnormality in the ductal and the aortic arch if it's not in the same direction. Any suspicion of coarct, I can pick it up in this view. And also the Doppler of ductus arteriosus is important in the 3rd trimester. Premature ductal closure is also possible. Usually, indirect signs, you will get it in a 4-chamber view before you reach the arch view. Now, this was related to the structural analysis, structural understanding of the fetal heart. However, there is also a component of functional assessment. We will not go into the rhythm understanding in detail, but there are just 2 slides to have just an idea about what we are going to see in terms of rate and rhythm. And all of you know that the parts of systole and diastole, systole is divided into IVCT and ejection. Ejection is a part which we can pick up in fetal echo. And in diastole, you have 4 phases, IVRT, rapid inflow diastasis and atrial systole. And the 2 most important component, rapid inflow and atrial systole, can be picked up in fetal life. And how do we pick them up? I will go through it. Before that, we need to know that there are important Dopplers in fetal life. This is how an IVC Doppler looks like, which is very similar to postnatal, where you have the SD wave and the A wave, which is much smaller, especially in later 2nd trimester and 3rd trimester. The pulmonary vein Doppler, you can see here, again, you have a dominant SD wave, very similar to that you have a PFO. The AV valve Doppler, as you know, the E and the E wave velocity is lesser than the A wave. The semilunar valves, which have a systolic flow, and the ductal arch. These are the basic velocities which need to be checked. But also important is ductus arteriosus, umbilical artery, umbilical vein, uterine artery, and uterine vein. How do I know the ejection? Very easy. Any Doppler of the outflow tract is going to give you the understanding of the component V, that is the ejection. If you Doppler the AV valves, you have the E wave, which is smaller than the A, and the E is the rapid inflow, and the A is the atrial systole. I can also pick up atrial systole in the SVC, ductus venosus, and pulmonary veins. So this is how ductus venosus Doppler will look like. This is AV valves, and this is the aortic or the pulmonary valve. And remember, the cornerstone for diagnosis of rhythm abnormality in fetal life is usually M mode and Dopplers. There is a way for us to pick up the PR interval, which is a crucial component in picking up first degree heart blocks, and also the PR and the RP interval, which are used for differentiating types of tachyarrhythmias. And we will see this in detail. However, this is just a glimpse of it. You need the outflow tract and inflow, LV, inflow, outflow tract, where you can have the Doppler of inflow, outflow together, and the A wave is going to indicate the PR interval here. And the SVC aorta Doppler, where you can pick up the PR interval. There are also ways to pick up ICT and IRT and ejection time, and this is used for diagnosing MPI. This is a functional assessment which is possible in fetal life. Additionally, we also have cardiac biometry. Now, in general, every single time, I do not need to measure the sizes of the valves, a gross side if it looks okay. However, it is important to understand that the AV valves are measured in diastole and the seminal valves are measured in systole. But in fetal life, the seminal valves sometimes are better seen in diastole. So you could take that call. Sometimes you could measure it in systole, but ideally, the AV valves are measured in diastole. The end diastolic measurements of ventricles are considered just below the AV valves. This is important when I try to find out if my RV and LV is proportionate or not. The thickness of RV and LV free walls is sometimes important in terms of hypertrophy, in terms of a mother being diabetic. The RV and the LV length is important, but remember RV and LV should be reaching the apex. The aortic and the pulmonary valve, as we discussed, ideally should be measured in systole. In the three vessel view, I can measure the isthmus and the main pulmonary artery and compare the diameter and the cardiothoracic ratio. So these are the 2D and M mode biometric measurements. We need to take a call individually when which measurement is important, and not every single measurement is taken if everything looks okay. I think this is sort of a completion of our understanding of anatomic and functional assessment. At the end of it, before we close today's session, the fetal cardiovascular profile score is important for us just to have an understanding. So I'm going through it. There are basically 5 things which need to be seen for a cardiac functional assessment. Hydrops, I know if I have no ascites, no pleural effusion, and no pericardial effusion, it is completely normal. And then I check for any of these skin edema. Second is cardiomegaly, as I know that the cardiothoracic ratio should not be more than 0.45. However, there is a small size also which is acceptable. Anything which is lesser than 0.35 or more than 0.5 is abnormal. Cardiac function, I see my tricuspid and mitral valve Doppler, and I make sure that I have E and A separate waves in the inflow Doppler, whether I have any tricuspid regurgitation which is holosystolic, or I have a mitral regurgitation which is holosystolic. So these are the things in AV valve Doppler to be checked. The umbilical Doppler, the arterial umbilical Doppler normally should have a positive flow in systole and diastole also. If I don't have a flow in diastole or I have a reversed flow in diastole, that's abnormal. The venous Doppler, the umbilical venous Doppler should be like a smooth, continuous flow in systole and diastole without pulsations. If I have pulsations, it's actually considered to be an ominous sign. And the ductus venosus Doppler should normally have not much of reversal in atrial contraction. But if I have atrial contraction reversal, it is abnormal. So this is how an abnormal CVS score will look. Here you can see there's significant amount of effusion, pericardial and pleural. If my cardiothoracic ratio is increased, if I have pansystolic AV valve regurgitation, if I have no diastolic flow in the umbilical Doppler, and if I have reversal in the umbilical, in the ductus venosus Doppler. So this is all which is abnormal. Normal score is 10. So usually it is scored 10 out of 10, which is normal. This is how a cardiac functional assessment is done. I think we will end our session today. If anybody has any questions, you can put it in the chat box.